Good evening, everyone. I'm your host again. My name is Sajid Malik. I'm Upper GI consultant, and today we are here in the fifth episode of the ELSA TV channel show. And we have a privilege today to have Professor Kazunori Kasama with us, who is a well-known and the world-known, basically, past president of IFSO APC chapter. Is a bariatric surgeon. And let me introduce a little bit about Professor Kazunori Kasama for the audience who don't know, like everyone know you very well, but for the brief introduction, like what exactly you have gone through after your graduation. Currently working as a director, weight loss and metabolic surgery center, also a medical club in Japan. And after graduation in 1990, correct me, and he worked into the various departments and worked as a past president and international for the IFSO APC chapter, past president of APMBSS, governor ELSA, and the treasurer of the ELSA as well, governor of IFSAS, executive board of the JSIS, and chair of the International Affair Committee of the JSIS. He is an honorary member of Venezuelan Society of Bariatric and Metabolic Surgeries, honorary member of Indonesian Society of Endoscopic Surgery, and honorary member of Chinese Society of Metabolic and Bariatric Surgery, and IBC Club as well in Oxford. So really, we are thrilled and excited to have Professor Kasama with us today to talk about the various questions in bariatric surgery which are still unanswered, and some future, what exactly we are going to see in the future about the bariatric surgery. So thank you for your time. So working as a full-time consultant in busy field of bariatric surgery and same time working for the various societies as a leading presidential role, as I was just talking, and being a role model for all of us. Prof, what are your career inspiration and how did you manage to balance all these multi-dimensional tasks on one platform in one year?
Yeah, thank you, Sadiq, for kind introduction. So actually, I just doing what I love to do. You
Mm,
know, the so commit with society is also very exciting to me, and of course, doing a bariatric surgery and the play a role of the pioneer of the bariatric surgery in Asia is really exciting things for me. So yeah, I paid all my effort to do to be a bariatric surgeon for a long time. So actually, that it's a little bit very busy schedule, but
mm.
I really enjoy the life.
Good. I know about the jiu-jitsu as well. You're a master of jiu-jitsu
Yeah, yeah.
champion. So that is another dimension people, probably the viewers would not be knowing about it. So let me introduce another part of the Professor Kasama as a jiu-jitsu master and a high deep sea scuba diver as well. So a really inspiration for many like who are thinking that they are multidimensional, but I haven't seen a multidimensional person like you. So, Prof, tell us, tell the audience, like, as a minimally invasive surgical technique continued to develop in the last 7 decades, and first surgery, I believe, into the bariatric surgery was done in 1966, and there was a time with sleeve, then RYGB, then we moved on to the SADI, MGB, OAGB. Do you foresee any significant changes in the way bariatric surgeries are dynamically moving and shifting in the next 5 to 10 years?
Uh, so the first big movement of the bariatric surgery is a converted from open surgery to
Mm,
laparoscopic surgery, as you know. So that the bariatric surgery has the biggest advantages of laparoscopic surgery because the open surgery of bariatric surgery was awful. The
yeah,
high rate of complication and the high mortality. But
yeah.
change to the laparoscopic surgery, it's become very minimum invasive surgery.
Mm,
Comparing with other surgery, bariatric surgery, laparoscopic bariatric surgery is dramatically changed from open to laparoscopy. In the
mm,
next 10 years, so there is they maybe have a change from less, much less invasive surgery.
Mm,
You know, like from laparoscopic surgery to endoscopic surgery,
mm,
or the I don't think robotic surgery is less invasive than laparoscopic
mm,
surgery. But of course, robotic surgery, one of the choice,
mm,
will be the one of the choice also in Asia. And also that what I'm thinking about is in combination with medicine. So
okay. Yeah.
recently, the improvement of medicine for the weight loss is is really a game changer of this field.
Mm,
But medicine itself has some limitation in
mm,
terms of weight loss,
yeah.
in terms of amount of weight loss in comparison with surgery. For
Mm,
that, so in combination with medicine and also the less invasive treatment, like
yeah.
balloon or like ESG, endoscopic sleeve gastroplasty,
Yeah. Yeah. Yeah.
and the others, uh, maybe has a almost same result with surgery.
Okay.
Yeah,
Mm,
so that every treatment
mm,
will forward to
mm,
less invasive one, right? So
yeah.
that
Definitely.
in combination with some medicine and some less invasive treatment will be one of the future.
Mm,
Yeah.
okay. No, and also there is a lot of medical tourism. You can see the people are moving, especially from the west. They're going towards the eastern part of the European countries, and from the uh, eastern part of the countries, they are going into the Asian countries, into the Far East, and from the Far East, people are going to the South Asia, and all these movements are basically medical tourism is also into the Middle East as well, because of the money is one of the reasons attracting all these peoples. So there is a big ethical question I'm going to place in selecting these patients due to increased medical tourism. And there is a growing emphasis on prehabilitations. So I'm afraid that into the medical tourism, pre-operative assessment and the post-operative provision of the care, which is integral part of the bariatric surgery. So, do you think that this is there any specific component you consider most crucial in pre-op and into the post-operative care, and how should a bariatric surgeon who is offering medical tourism, especially onto the bariatric surgery, should develop his practice in collaborating with the specialties?
Mm. So medical tourism is a big issue among ELSA committees.
Yeah.
Yeah, so that so bariatric surgery not is not only one-time surgery.
Yeah.
So to get our best result,
Mm.
important thing is the follow-up.
Yeah.
Yeah, if you do a surgery, bariatric surgery, and say goodbye to your patient,
Mm.
results may be not as good
Yeah.
as we did. So
Absolutely.
that among the ISO executive board and also ISO committees, we think that medical tourism
Mm.
is a real bit
Tricky,
problematic.
let's say.
Yeah,
Yeah. It's
tricky
a
to
tricky
describe.
thing. Yeah.
But as a matter of fact,
Mm.
the, there is a medical tourism from Western country to Asia
Yeah.
because of the
Right.
cost,
Yeah.
because of money.
Yeah. Exactly.
So, so, so what we should do in the Asian Bariatric Society is to provide uh, very safe surgery, and also that you have to make a way to provide good follow-up
Mm.
for the patient if the patient go home after surgery. Yeah. So as you know that bariatric surgery is a benign disease surgery.
Mm.
If the mortality happens, it will be the disaster of
Yeah.
surgery. Yeah. So that we are very careful to provide the
Mm.
medical tourism Yeah.
Absolutely, absolutely. I remember we used to do comms clinic when I was doing fellowship with Professor David Lumonto and Professor
Mhm.
Asim Shabir in bariatric surgery and upper GI and MIS. There was a very strict criteria to as an inclusion criteria for the patient who are coming in center of obesity and metabolic surgery, not to hire all patients.
Yeah.
Patients have to show some personal movement, like in terms of the weight loss. It's not like patient is coming in, okay, you offer the bariatric surgery, and then okay, you go home and then there is no follow-up. So I think the preoperative psychological assessment and physiotherapy, initial weight loss, and all these things which are basically very important to be considered.
Yes, that's true.
Yeah.
So,
And while the robotic has become increasingly common in many surgical field in adoption, as you just said, the robotic might be the late upcoming into the bariatric surgery as
mhm.
we have a big room into the abdominal cavity. What do you think about the potential advantages and limitation of the robot assisted bariatric procedure? The question would be because when we talk about the artificial intelligence, the question would be, are the robot going to take up my job into the that is like a common question. So of course, robot is not going to take up your job. You need to simulate it. But so how helpful the robots would be into the future in bariatric surgery? Are we seeing foresee in 10 years, 20 years, or just we are relying more on endoscopy and laparoscopically?
Mm. Yeah, robotic surgery is the one of the future of our field. I mean, the all of them, the laparoscopic and endoscopic surgery,
Hmm.
we cannot deny the robotic surgery.
Yeah.
But still, in the field of bariatric surgery, we don't have any evidence that the robotic surgery is better than laparoscopic surgery.
Hmm.
But um, maybe this is my still my personal opinion. But for the very heavy patient, I mean the BMI over 60 or 70, so such kind of patient, robotic surgery is useful because
Hmm.
the robotic surgery can lift the abdomen,
Abdominal
right?
wall.
The abdominal wall, that's right.
Yeah.
Yeah. So that can provide a bigger surgical field than the
Hmm.
usual laparoscopic surgery.
Hmm.
But
Hmm.
to tell the truth, the I haven't had any experience of robotic surgery in the field of
Hmm.
bariatric surgery.
Yeah. Yeah.
Yeah. But the AI will be the one of the most part of our practice,
Hmm.
but they cannot replace surgeon.
Hmm.
At least this 1 or 2 decades, maybe.
Hmm.
But for the selection of patients or some, the preoperative examination or the diagnosis after the examination, the AI will
Yeah.
play an important role.
Hmm.
And also the during surgery, AI will play some navigation.
Hmm.
Yeah. But surgery itself, even we use a robot,
Yeah.
surgery itself will be done by surgeon,
Hmm. Yeah. Exactly.
right?
Yeah.
So that still the robotic surgery, I think robotic surgery is much slower than our laparoscopic surgery.
Hmm. In terms of
Yeah.
the setting up the docking process and also in terms of the learning curve or in terms of the achievements of the results, basically.
No, no, I mean in terms of the manipulation.
Okay. Okay. Hmm.
Yeah.
Good.
So yeah, from my viewpoint, the
Hmm.
my suturing is faster than robotic suture, right?
Hmm. Okay.
Yeah.
No, that's true. That's
Still,
true.
still
That's
robotic
true.
surgery is not that quick.
Hmm.
The expert laparoscopic surgeon.
Yeah.
Yeah. Because
Yeah.
yeah, but the so looking back to AI,
Yeah. 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 I was
yeah.
about to ask.
So the AI will be very important of the pre-surgical the period and also the follow-up.
Yeah. Mm.
Yeah,
In
not
terms of
surgical.
making plans and yeah.
Yes.
Yeah.
So plan of the surgery and
Mm.
which patient will be the
Yeah.
good candidate of surgery and
Yeah.
which procedures is good for
Yeah.
this patient.
Mm.
So we can have a decision by
Yeah.
AI.
Yeah.
Yeah.
Good. Thank
So
you.
that
Thank
AI
you.
will be the helper of our
Mm.
surgery, but they cannot be a surgeon itself.
Yeah, of course. So, so definitely our job is not being taken up.
Yeah,
Yeah.
but for other medical fields, like
Mm.
the just the diagnosis
Mm.
department will be
Yeah.
replaced by AI.
Yeah, exactly. Especially the endoscopy in upper GI, which is largely is being held by the AI, artificial intelligence
Yes.
in
So
surgical endoscopies, basically. Yeah.
yeah. So for the diagnosis, it's being
Mm.
replaced. But
Mm.
doing a
In therapeutic,
procedure, yeah.
so that
Even
is a very good point. Yeah.
that's right. So
Mm.
we can use AI for diagnosis of endoscopy, but someone have to put colonoscopy inside.
Yeah, exactly. Yeah,
Yeah, right?
absolutely.
Right. So
Absolutely.
diagnosis is for
Mm.
AI, but the procedure itself is by surgeon or the endoscopist
Yeah,
itself.
absolutely.
Right?
Absolutely. Thank you, Prof. I'm going to ask about the revisional surgeries after the failed primary procedures, which is a
Yeah.
very hot debate topic, basically, especially in mini gastric bypasses or onto
Mhm.
the OGB when the two procedure like either they're more getting more fame due to less complication, but fail to achieve the extra weight loss. Um, in terms of the revisional procedure, so what is your advices in terms of the pouch, like lengthening of the rule limb or the correction of the large gastric pouch and the stoma, or taking down the gastric gastro fistula and the what is your basically what do you do in your practice as a revisional procedure in these patients? Would you do recommend a lengthening of the limb or correction of the pouch? So what's your thought about it?
So you mean after one anastomosis gastric bypass?
Yeah.
Okay. So actually that I haven't do about one anastomosis gastric bypass
Okay.
because of the some particularity in Japan. So we
Mm.
cannot have a bypass stomach because of the gastric cancer.
Oh yeah, 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 exactly. Yeah,
You know that the
definitely.
gastric cancer is
Yeah,
a very
yeah.
frequent disease in Japan, the
Very
Korea, and
prevalent.
also
Yeah,
some part of
exactly.
China.
Absolutely. Yeah.
Yeah, so that the bypass stomach, which we cannot examine by endoscope, is a little bit
Mhm.
risky.
Yeah.
Yeah, to leave behind. So
Mm.
that in my personal experience,
Yeah.
I haven't have any one osmosis gastric bypass,
Mm.
but I started doing my gastric bypass
Mhm.
in the first period of bariatric surgery.
Mm.
It was 2002 when I started bariatric surgery.
Mhm.
At that time, there was no sleeve gastrectomy,
Yeah. Oh,
only gastric bypass or
that's bypass.
yeah, vertical banded gastroplasty.
Mm.
Yeah.
Okay.
So my first bariatric surgery was my gastric bypass.
Mm.
And then at that time, if the um, weight regain happened after
Mhm.
gastric bypass, it
Yeah.
is really, really hard to have a decision how to make a revision surgery.
Revision surgery, especially in
Yeah.
the yeah.
For the gastric bypass. Also, the mini gastric bypass are same. So
Yeah.
that the revision surgery for the bypass is what I did is trim the pouch. Usually that the if the patient have regainable weight, the
Yeah.
pouch enlarged and also anastomosis
Yeah.
enlarged.
Yeah, exactly. Yeah.
Yeah, what I did is trim the maker pouch smaller and
Mm.
also
Making the
the
anastomosis smaller.
making anastomosis smaller
Mm.
by reanastomosis.
Okay. You
And
don't
that
do
time,
you
and
don't
also
prefer
that I make a
lengthening.
luring longer. Make a
Okay.
BP limb longer, not a luring, BP limb longer.
Okay. Okay. Not the
Yeah,
ruling. Mm.
and my majority of a procedure now in Japan is a sleeve gastrectomy.
Okay. Okay.
Yeah, but sleeve gastrectomy, as you know, have regainable weight and also
Yeah.
failure of weight
Mm.
loss, especially
Mm.
for the BMI over 50.
Okay.
For
Okay.
the very obese patient has a
Mm.
tendency to regain weight.
Mm.
For for that patient, I do a sleeve DJB.
Okay.
Yeah.
Mm. Yeah.
So and also that I do a wrist sleeve and cut the duodenum,
Mm.
the make a longer BP limb
Mm.
and do the sleeve DJB.
Mm.
You know.
Okay. Okay.
So to add malabsorptive procedure to a restrictive procedure is a key to success of the revision surgery in terms of weight regain and also the failure of weight loss.
Okay. Okay. Good.
So
And
longer BP limb is effective, but of course we have to think of the malnutrition after
mm.
the bypass surgery.
After, yeah, exactly.
Yeah,
Long term.
because you know that Asian patient has much less protein intake
Yeah,
than Western country.
exactly. It's a more intake of the carbs as compared
Right,
to
that's
proteins.
right. So if you do a very long BP limb and very short common channel,
Mm,
you may encounter the protein malnutrition.
yeah,
Yeah.
that's true.
Actually, that
Mm,
we have many stories from India in
yeah,
the beginning of bariatric surgery.
yeah, yeah.
Yeah, they did BPDDS,
Mm,
just like the Western style, very
yeah, yeah.
short common channel, and
Mm,
they suffered from malnutrition.
oh, yeah.
Yeah,
Mm,
because the Indian people, some of the
the-
Indian people are the vegetarian
mm,
and quite less intake of protein.
yeah.
And also, I have a one patient who had not very severe, but had developed protein malnutrition after
Mm.
my first
Oh,
BPDDS.
okay, after the BPT.
Yeah.
Mm,
So after that, I think we have to establish the Asian bariatric metabolic surgery.
yeah,
It's not exactly the same with
yeah,
Western style,
yeah, exactly. Because of
right?
the ethnicity, because of the patient's requirement is different, food is
Yes,
different.
that's right.
And our BMI is also different, Prof. As
Yes,
compared to the Western. We have a more central obesity as compared to the Western population, who is like
yeah,
more generalized obesity. And
yes.
yeah.
And the frequency of the diabetes is
Mm,
more
yeah,
Western country
yeah.
in Asian country, and also the average BMI of the diabetes people is much
Mm,
less in the Asian country in
yeah,
comparison with
exactly.
Western country.
Exactly. I
Yeah,
think because of the compliance and because of the compliance of the patient in terms of the food, self-care, so many factors being especially in the low socioeconomical part of the world, it's more it's more problematic as compared to the richer side of the world, which is as compared more focused and oriented in terms of the self-care, in terms of the provision of seeking care as well. Like in if we talk about like into the South Asian countries, seeking of care is also extremely difficult, and not a seeking of care, but actually seeking of a good care is
hmm
difficult. Yeah,
yes,
that is because just like medical tourism, there is a lot of without blaming anything, just discussing about like there is a lot of care providing websites and the data available which is unauthorized, and the people start following those data and then will end up into the problems. Yeah.
Yeah, that's true. Yes.
Yeah, probably I have another question about the indication into the in terms of the transplant eligibilities, because when we talk about the cirrhotic liver, when we talk about the chronic kidney diseases and the patient with end-stage liver failure or the kidney failures, who are actually a candidate for the transplant, but they cannot get the transplant because of the high BMI and the
Hmm.
upper limit is 40. On the other way around, which is in itself is an indication for the bariatric surgery because the BMI is more, it is
Yeah.
a 40. Yeah. So, in your opinion, because the people are now offering bariatric procedures to these patients who are actually a future candidate for the visceral transplant, especially the solid viscera, kidney and liver. So, what's your opinion? Have you come across in your practice about these patients who are being
Mhm.
referred for a bariatric procedure for optimization before the transplantation? Or what are your thoughts about in terms of the management and what should be the ideal procedure for these patients?
Okay. So the recently that IFSO and the SMBS they published a guideline 2022,
Mm,
and they also conclude the bariatric surgery is good for the bridge to
mm.
transplantation.
Yeah.
Yeah. So of course I have some patients the who had the sleeve gastrectomy as a bridge to transplantation because the obesity is a contraindication. Severe obesity is a contraindication to be a donor and also a recipient
Yeah.
of the organ transplantation. The of course that after bariatric surgery they can reduce the weight and their the function is a little bit improved, or the they can manage the end of stage renal
Mhm.
failure,
Yeah. Yeah.
yeah, until the
Mm.
transplantation,
Yeah. Yeah.
so that in my opinion it's not decided yet in the worldwide, but in my opinion the best procedure for such kind of patient is a sleeve gastrectomy.
Okay.
Yeah, sleeve gastrectomy is safer than other bypass procedures,
Okay.
and
Mm.
the sleeve gastrectomy doesn't need to manipulate uh, small intestine.
Mm.
Yeah, very simple procedures.
Yeah, exactly. It's a yeah quicker,
Yeah,
safer,
that's
and
right.
is um, I mean the results are also the weight loss is quicker as well as compared to
That's
the
right.
bypass, which
Yeah.
is a longer procedure, which is it involving anastomosis and prolonged stay of the patient into the hospital. So a lot of things into the bypasses as compared to the sleeve. Yeah,
Yeah, that's right. Sleeve gastrectomy is not a perfect procedures,
yeah, of course.
but a good procedure for many
As
people.
a bridging process for especially for these patients who are not meeting
Yes.
the criteria of the transplant and could be a
Yes,
good candidate in the future for the transplantation.
that's right. Yeah.
Mm. Would you advise any special any concerns or the special advice to these to the young fellows who if get these patients in terms of the collaboration, of course with the transplant apart from the transplant surgeon,
Mm-hmm.
especially for the patient, would you divert your practice in post-operatively in terms of selection of the multivitamins because they are already having an insult into the kidney and the liver, and provision of the multivitamin which is being have to be excreted by the GIT and the kidney and the liver. So would you post-operatively divert some practice on these patients, or will you keep it unique as in the routine sleeve gastrectomy patients?
So, of course, the the organ function of such kind
Mm.
of patient is very severe,
Yeah.
right?
Yeah.
So that we have to pay much attention
Mm.
for that patient in terms of the nutrition.
Yeah.
Yeah. And of course, we have to make a very nice relationship
Mm.
with their physician
Mm.
to take care of that patient.
Yeah.
Yeah. So, and also the our nutritionist plays very important role.
Yeah. Absolutely.
Yeah.
Absolutely. Mm.
Probably more important than
Then
surgeon.
this exactly because we have a surgeon have a one-time job, and the
Yeah,
nutritionist
that's
have
right.
like a continuous job, like for the next
Yeah.
10 years into the bypass, you do it, and then nutritionist and the physiotherapy are the people like who are doing their job
Yes,
permanently.
that's right. So
And this
important thing is that we need to make a very nice team.
exactly,
Yeah,
exactly.
to take care of our patient.
No, this is I learned when I was working in Singapore with Professor David Lumanto. He's into the meeting already. The patient won't come into to meet the bariatric surgeon unless he have been seen by the psychiatrist, because of course, it does involve into your mental health. If you're losing a lot of weight, if you're developing malnutrition, or even if you're not losing your weight. And the second is the physiotherapy as well. If you're not aiming to lose weight pre-operatively, surgery is just a push. You won't be able to lose your weight post-operatively if you're not interested in yourself, like in
That's
terms
right.
of the losing. So it's
Yeah.
surgery is not a magic. It's not like cutting a stomach and then you get slim. No, is giving a chance to become slim, and then if you work more, there is the more chances that you will become slim quicker as compared without surgery. So that is a basically the true story of the bariatric surgery. Prof, there is the same thing, very tricky. I research on basically, and I publish my manuscript on it in ASMBS
Mhm.
from the USA. um, Maternal and the fetal outcomes in a childbearing age. The female especially of the reproductive age who
Mhm.
underwent bariatric procedure. So what I found is when they conceived after the bariatric surgery, there was small for gestational age babies, and there was no mental retardation though,
Mhm.
but the babies were small for gestational age, and on to the positive side, maternal benefits were preeclampsia, pregnancy-induced hypertension, gestational diabetes were less.
Mhm.
So, which is a good. So, what are your advices in terms of based on these results in collaboration with the obstetrician in a long term, especially into the females of the reproductive age, especially into this part of the Asia, where there is a family stress is more to get conceived, especially into the these female who is not conceiving. So this is a very sensitive, issue in most of the families in major part of the Asia as compared to the Western part. So what's your advices to the surgeons who are doing bariatric surgery in a reproductive age onto the females and in a long-term management plans and the
Yeah,
selection
a
of the
very
procedure as well.
yeah, that's a very nice question. And from the viewpoint of bariatric surgeon, the I saw the patient who had who was so
Mm.
delighted for surgery was the patient who get the baby after surgery.
Here
Right?
we
You know
go.
that before surgery, they pay
Mm.
huge amount of money,
Yeah.
yeah, to get a baby.
Yeah, exactly.
But yeah, because of the obesity, they
They can,
couldn't get
can yeah,
baby.
yeah.
Yeah,
ICSI
because
and
they had PCO,
mm,
yeah, polycystic ovarian diseases, ovarian
mm,
syndromes,
yeah.
and also that it was impossible to get
Mm,
pregnant.
yeah.
But after surgery, it was so easy to get the pregnant,
Yeah.
right?
Yeah,
And
exactly.
as a matter of fact, we already have more than 40 babies
Mm,
after surgery.
mm,
And
yeah.
all of the patient was very hard to get pregnant before surgery.
Mm,
They were so happy.
happy.
Yeah.
Of
And
course.
sometimes they brought their baby to my clinic
To the clinic as
and
well.
they showed how happy they are.
Yeah.
Yeah, that was very good point to be a
Mm,
bariatric surgeon.
exactly,
Yeah.
exactly. You're
So,
offering.
but of course, for the patient with reproductive ages, I recommend them to avoid to get pregnant the
Mm,
1 year after surgery.
yeah, 1 year. Yeah,
1 year. Yeah,
yeah,
that is uh just follow the guideline.
yeah, exactly. Yeah,
Yeah.
yeah, yeah, exactly,
So
exactly. Yeah.
just after surgery,
Mhm.
the nutrition status is not good
Yeah,
to be pregnant. So
yeah.
that 1 year is okay, but maybe the 9 months is okay. But I recommend them to avoid the pregnant for
Mm,
1 year after surgery.
okay,
And
okay.
then
Noted.
after 1 year, I say them, go as you like.
Mm.
Yeah, do as you like and
Good.
enjoy your life
Yeah,
and get
absolutely. And
right.
yeah, absolutely. As you said, in your practice, you do mostly because of the BMI and also the selection of the patient as a sleeve gastrectomy mode. So in these patients, in these females, would you titrate them for the sleeve or gastric bypasses, or would you use any criteria, or you will randomly, not randomly, I mean, assign them scientifically speaking as per to the original criteria, not considering them as a reproductive age female trying to conceive?
Mm. Yeah, the choice of a procedure is depending on the patient situation,
Okay, yeah.
usually.
Mm.
But I need to tell you that for these 10 years,
Yeah.
only sleeve gastrectomy is covered by national insurance.
Mm.
The
Okay.
coverage of the national insurance of bariatric surgery has started from 2014.
Nice.
Yeah,
Which is
but
good.
it was only sleeve gastrectomy, no
Mm.
bypass surgery.
Okay, okay,
Yeah,
okay.
but from this year, from this June, the sleeve DJB, the 3 plus, is now covered by national insurance.
Okay, okay. That's good.
Yeah,
That's nice.
so that
Mm,
we have a two choice
mm,
of the coverage of insurance,
mm,
but it used to have a sleeve gastrectomy only, so that all of my patient who could get pregnant
mm,
was sleeve gastric patient.
mm.
Yeah.
Absolutely, absolutely. I think the Japan is taking a leading role in the sense like offering bariatric procedure onto the national insurance. Most of the countries, talking about the Pakistan, other countries into the South Asia, and most
Mhm.
of the even the Western countries, they're still not offering bariatric procedure onto the national health services.
Oh yes.
Recently, NHS UK have recently started,
Mhm.
but there is a long, long waiting queue of like,
Yeah.
I'm not sure about the timing, but there is still. So Japan is taking a leading role on this point to offer since long time, like 10 years ago. So
Mhm.
many countries haven't offered this thing, which is good. Yeah,
Yeah, I'm
cool.
sure that the Japanese health insurance system is very
Hmm.
uh, affordable for my patient and also the very short waiting list in
Yeah,
comparison with other countries. So that
nice,
I think it's a very
nice,
nice system
nice.
for
Yeah,
patient,
exactly. Yeah,
but not for
exactly.
surgeon.
Yeah, of course. Absolutely. Prof, there is another question about
Yeah, sure.
any another area of concern in bariatric surgery is when we talk about the metabolic diseases,
Yeah.
diabetes, hypertension, and all these things. But there is another non-alcoholic fatty disease,
Hmm.
NAFT, and the non-alcoholic steroidic hepatic disease, basically.
Yeah.
So in these patients, because of the fatty liver, which is related actually indirectly or directly with the comorbidities,
Mhm.
and becoming more and more an indication for the bariatric surgery patient, despite of the normal, not normal, slightly onto the higher side BMI, who would actually won't be a candidate for bariatric procedure.
Yeah.
But this non-alcoholic fatty disease is making them to be a candidate for this patient. So would you offer mini gastric bypasses, or what do you do in these practice if you come across, and what would be your advices based on to the consensus, like what should be the ideal procedure for these patients again? Because it's not a short-term metabolic abnormality, it's like a long-term metabolic abnormality. Patient would need a results for a prolonged period of time. So what your
So,
advices are it?
yeah, for the non-alcoholic fatty liver disease, recently we call it the MAFD, metabolic
Yeah,
associated, yeah.
yeah, exactly. Yeah.
Yeah. And I also would like to tell you that I'm happy to tell you that from this year, June, our
Mhm.
government approved
Mm.
bariatric surgery for the MAFD patient.
Okay, nice.
Yeah, that's good for us because, yeah, our criteria is a BMI of 32 with two comorbidities, including diabetes, hypertension, the hyperlipidemia, and the sleep apnea, and MAFD. So
Mm.
among five diseases, if you have one or two diseases, so we
Mhm.
can do the surgery.
Okay, okay.
Yeah. And the recently just as I said that the MAFD is just included in
Into
the
the
into
national
the national the insurance
insurance.
criteria.
Mm.
Yeah, just from last month.
Okay, okay.
So the I think the improvement of the uh MAFD is
Mm.
rely on to the weight loss and also the improvement of diabetes.
Mm.
MAFD is a really have a close relationship with diabetes.
Yeah,
So that the sleep gastrectomy itself is also a very nice procedure for
okay.
them. In my colleague of Iwate University, Iwate Medical University, have
Mm-hmm.
a very nice paper regarding remission of the stenosis of
Yeah,
the map after sleep gastrectomy alone.
okay, nice.
Yeah, so that they prove that the fibrosis
Yeah,
is, yeah, can be a normal liver after massive
okay.
weight loss. Yeah, but cirrhosis is already established. Cirrhosis is not easy to reverse.
Exactly. Yeah,
Yeah,
yeah, yeah,
but NASH, the state of NASH is okay to
yeah.
reverse. Yeah, possible to
Mm.
reverse even after sleep gastrectomy alone.
Yeah, yeah, exactly.
Yeah. So of course, that the both of the bypass procedure, like mini gastric bypass, I mean the one osmosis gastric bypass and
Mm.
lower gastric bypass and sleep gastrectomy, both all of them are very nice procedure for MAFD.
Mm. Okay,
But
okay.
yeah, one of the factor we have to concern is if the patient developed severe the cirrhosis, sometimes bypass procedure risky.
Okay.
Yeah, like in a mini gastric bypass, like a the short common limb bypass,
Mm-hmm.
sometimes develop the liver failure after
Mm.
cirrhosis. So
Okay.
if the patient already developed the liver cirrhosis, I
Mm.
usually avoid bypass procedures.
Mm.
So I have
Okay.
one patient who developed the from liver cirrhosis to liver failure a few years after bypass procedures.
Mm.
So that I usually avoid the bypass procedure for the severe the liver cirrhosis patient.
Okay.
Yeah, sleeve gastrectomy is okay. As I said, that sleeve gastrectomy is a perfect procedure, not a perfect procedure,
Yeah,
but good
but it
for
is.
the almost every patient.
Mm. It
Yeah,
fits everyone.
yeah.
Yeah. As we were talking about in the beginning about the
Mhm.
future of the bariatric surgery,
Yeah.
um, endoscopically, or the medicines, or the holistic approach in different parts of the world, different practice is still in the practice. So,
Yes.
with the rise of this GLP-1 analogs, basically, so do you foresee into the future the medicines are going to take up more job, or any magical pill is going to take up a job as compared to the bariatric procedures? Because people are still afraid of being having a cut, so they are still prefer, is there any magical pill? So there were like injections, tablets. So what's initially started with the tablets, and now we have this GLP agonist. So what do you characterize your patient based on to the patient profile, or would you recommend GLP agonist to these patients as a adjunct to your bariatric procedure preoperatively, or not at all?
Yeah. So that yeah, GLP-1 analog is a very nice medicine for the so-called neoadjuvant, like before surgery.
Yeah,
Yeah.
exactly. That's a two word for the new adjuvant for the
Yeah.
bariatrics. Yeah.
And also that the goods for the adjuvant therapy for after surgery if the patient has regained weight.
Yeah.
Yeah, just
Mm.
like a chemotherapy of the
Yeah,
cancer
exactly,
cell.
exactly. That's
Yeah.
why I asked this particular question, because people would basically are deciding either to go with a revisional procedure, or to after the first bariatric procedure, or to go with these analogs to
Yeah.
opt after the bariatric or in adjuncts to the bariatric procedure.
Yeah. That
So,
problem is the same as the chemotherapy, the
mm,
cost.
mm,
Yeah, cost of using a medication for a long time is
mm,
very uh, high cost.
mhm,
Yeah. So if the patient is 25 years old and they started GLP analog, but they if they stop the GLP-1, they may
mhm.
regain weight, right?
Okay. Yeah. Yeah, exactly. Yeah.
But I don't think it's very fair to use a GLP-1 analog for 50 years,
Mm.
right?
Yeah.
Cost of that, the long-term GLP-1
Is
analog is offer,
Yeah, exactly.
Yeah.
Unimaginable. Yeah, exactly.
So in terms of the cost effectiveness, the
Mm.
surgery is better than the medication
Mm.
nowadays. But I
Mm.
don't know the future. If
Yeah.
the affordable, yeah, medicine and just take a pill once a week and
Very cheap as well.
really replace the surgery.
Mm. Yeah.
But
Agree.
usually the pharmaceutical company
Mm.
will not provide such kind of cheap
Yeah.
drugs
Yeah.
because they are business,
Yeah.
right?
Absolutely. Yeah.
Yeah.
Yeah. I agree with you. Yeah, I agree with you. And Prof, in your expert opinion, what are the most promising, like based on all these things, like when we are talking about the future of the bariatric surgery, what are the promising area in the future you foresee in terms of the research in bariatric, which should be opted to the young fellows, young surgeons who are coming to the bariatric surgery to explore in terms of like in terms of basically whatever being provided is basically in terms of the provision of the best health care to the patients. So what are the areas in the future for the research you would advise to the young fellows, young bariatric surgeons? I would consider myself young as well.
Okay, so yeah, still the indication of bariatric
Hmm.
surgery and bariatric metabolic surgery
Yeah.
is I don't think it's very appropriate.
Hmm.
For usually that this is the bariatric metabolic surgery applied for a BMI over 30 or
Okay.
20. Yeah. So there maybe has a patient the BMI less than 30 and can get the benefit from surgery.
Mm.
So in terms of uh, metabolic
Mm.
improvement.
Yeah, yeah.
So now I do the randomized control study for the
Mm.
BMI about 27.5
Okay.
to, yeah, for strip
Mm.
JB
Mm.
in comparison with the medical treatment, including a GLP-1 therapy
Yeah.
for diabetes.
Mm.
So even the BMI is less, the some patient can get the very nice result
Yeah.
after metabolic surgery.
Yeah.
So that
So,
I still think that we can have expand the indication of surgery.
mm.
And
Okay.
still, we don't know why we can have remission of diabetes or other medical diseases after
Mm.
metabolic surgery.
Yeah.
Yeah,
Absolutely.
still we don't know
Mm.
completely.
Yeah.
So that there's a huge field of research of the metabolic surgery in
Mm.
Asia. So the many of the research are from Western country, like United States and Europe and the South Africa.
Yeah.
But we we need to have Asian evidence
Yeah.
to provide uh, good
Less.
treatment for Asian people.
Yeah. Absolutely.
Yeah,
Absolutely. Because the British Society of Bariatric and Metabolic Surgery, they have changed, expanded the indication, as you said, especially for the Asian population.
right, right.
Asians living in the Western countries, they have reduced the BMI even without comorbidities to 2.5
Mm-hmm.
uh, from the normal. So even without without diabetes or anything, so 27.5, they have brought the lowest BMI to 27.5 with new onset diabetes as an
Mm-hmm.
indication for the bariatric surgery
Yes.
into the breast. So yeah, it's like surprisingly because of the it's more central associated with the comorbidities is higher. Yeah. So we are approaching a time limit, Prof.
Oh
Just
yeah, already.
it's
It's
like one
really
of
nice to
the
talk with you.
yeah.
It's
Thank you
been a
so
long
much.
time.
Just last things. In terms of the training opportunities in
Mm-hmm.
the young bariatric surgeons, especially when we are talking about the ELSA platform, ELSA outreach programs, and especially thank you to the JSS, Japanese Society of Endoscopic Surgery, providing opportunities to the ELSA OP countries from the low social economical countries who don't have the opportunities to move, especially under your supervision because you are the master of the bariatric surgery for the ELSA basically. So what are the training opportunities you would give advice to the young fellows who are looking to come across out of their countries to learn for short fellowships of 1 year, 6 months, 2 months, 2 weeks, something? Because the most of the people they try to go to the Belgium or other Western countries, without mentioning any names. But the cost is very, very higher.
Yeah.
But the ELSA is providing scholarship programs and everything. So please, over to you to advise this to the young fellows, how they can apply, how they can get this benefit directly from you and from the ELSA team.
Thank you. So now the with Professor Romanto and the ELSA OP team, we are making a plan to provide a mini fellowship with
Mm.
JSS.
Mm.
Yeah. So now I play a role of the International Affair Committee of JSS, and so that we are thinking of the plan to provide the
Mm.
opportunity to come to Japan,
Mm.
and of course, including a bariatric surgery and other fields like colorectal surgery, upper GI, and hernia, and HPV. So
Yeah.
we will provide some mini fellowship program in
Mm.
the relationship with ELSA OP and JSS.
Okay.
Yeah, so that for the ELSA OP country, for them it's really expensive to come to Japan and other country, but we can
Yeah.
support them.
Okay, that would be
Yeah,
very extremely benefit and useful for the young fellows.
yes. And also that in terms of the bariatric surgery,
Mm.
the if so
Yeah.
can provide some opportunity for
Mm.
the clinical fellowship.
Mm.
And also that we our the hospital, Yotsuya Medical Cube
Yeah.
can provide some clinical fellowship, hands-on fellowship
Mm.
to Asian surgeons.
Mm.
We already have more than 25 international fellow
Oh,
to
nice.
have air clinical hands-on fellowship in my hospital. So
Yeah.
we also accept the clinical fellowship among Asian countries.
Yeah. Mm. Nice, nice. I think that's a very, very would be very exciting for our viewers who are watching at the moment or would be watching later onto the YouTube so they can explore your center. I will put into the comments to
Hmm.
apply for these clinical attachments and to the fellowships with you and in other specialties. So the time is getting over. Thank
Yeah,
you, Prof.
yeah, it's
Uh,
really my honor and the pleasure.
No, no, thank you so much for giving us the time from the busiest schedule of yours, being a so busy in terms of the three main dimensions, being a clinician, and then the managerial role into the society, and then the family, and along with your commitment with this jiu-jitsu and the scuba diving and all these things. Thank you, Prof. The last advice you want to give to you viewers as a all yours, like just a short comment to the viewers in terms of the bariatric surgery.
So yeah, just a short comment to all the viewers. So if you want to be a good laparoscopic surgeon, train hard. Yeah, practice is everything.
Good. And I think I was with Kyo a few weeks ago, and then there was a word in Japanese I forgot about. Work like a bee, but there was some specific word into the Japanese when you do the this jujutsu. There's some special word I forgot about it. Sorry.
No, it's okay. Yeah.
Okay. Thank you,
Thank
Prof. Thank you, viewers. Thank you, Professor Kasama. Professor Kazunori Kasama is a well-known again bariatric surgeon, and he's executive member of ELSA Society and we will talk to him again on other platforms during ELSA Bali and also in Singapore and also into the upcoming events and in many outreach programs again and again and probably onto the webinars. Thank you for watching and I would request to subscribe to view the latest updates. Don't forget to install the ELSA app because the whatever we are talking about would be going into the incorporate into the ELSA app. And ELSA app is not like an app, it's more like a dynamic app, which is being updated onto the daily basis to have the latest news, the fellowship program, which Professor Kasama was telling about. All those would be announced through the ELSA app, basically. So thank you so much. Hope to see you in. Don't forget to get registration with the ELSA Bali event, which is in August 2024, and World Congress of Hernia Surgery, which is being a sister society with the ELSA in October 2024. Thank you so much.
you. See you in Bali.
Thank you.